thank you, David, and thank you, everybody. Just two things to say following that embarrassing introduction. One is, we have 4 daughters, and one of whom describes me as the nerd. So it's going to be difficult to fantasize of what David has said is how I should understand myself with their constant presence, I'm pleased and reassured to say. And I'm so proud of them and all they achieve. The second thing is, it's true what he said, and I have shaken the Queen's hand. And I have to say that as the years go by and I'm surrounded by powerful figures like Mr. Murdoch, Mr. Cameron, Mr. Gove and Mr. IDS, I have come increasingly to feel the bastions of values I admired are actually amazingly, tragically, most strongly represented in our formal institutions by things like the House of Lords and the Queen. And that is a shocking political conclusion to come to, especially when I listen to the kinds of speeches that most of the contenders for the Labour leadership have to make these days in Britain. But that's not what I've come here to talk about, and this is a very serious time for all of us, as well as I think it's an exciting time to be at an event like this, and I'm really grateful to be here. I'm pleased, it's a privilege. And it feels like it's more set out for dancing than this. But I did want to say something, my own version of myself, because I think it's very important that we are honest about ourselves, and we are honest about where we come from, because so often where we come from dictates how we see the world. There's that bit, isn't there, which is variously attributed to the Talmud and to various other things, which is that we see the world not as it is, but how we are. And I think that that is a very, very current way of thinking about things, even if it has a history. I'm always interested to find out where people come from, because it gives me an idea how much I may be able to trust them. And a lot of what I feel I'm talking about, we're talking about, is about what confidence and trust we can give to what people have to say to us, who we are, what influences us, and so on. And of course, the point I want to make by way of introduction is that who we are is always complicated. And you've had a version of me, it's not the version that I can identify with really, but none of us are one simple or single thing. Although events in our life, aspects of who we are, can make it that one experience, or what's seen as one aspect of us, can dominate how we are understood, and even how we come at things and understand ourselves. So I do tend to get described at events like this as someone who works in a university and also perhaps is involved in service user organisations. I am proud still to be working in a university and doing research and having colleagues. And I think one of the things that David said I do very closely value and relate to, which is the point he made about having collaborators. And I really do incredibly value the people that I've got to know through the movement that I'm part of and through the work that I do, both as friends, as collaborators, and as fellow travellers in life. And they've given me enormous strength in being able to deal with my life over the last X number of years. As people know, I've got a background of using mental health services, and I'm very proud to be associated with an organisation, please do Google us, Shaping Our Lives, which is independent, which is a user-controlled organisation, which I was just thinking this morning of the spirit of our different workers over the years has been true to a determination to try and be as inclusive as we can around all sorts of dimensions of identity and difference, not just those to do with, let's say, communication or environmental aspect, but all those issues which are incredibly difficult sometimes to deal with and important, but also all those issues of difference to do with many other things, and there's some insights into just how extensive those can be and how big the barriers can be. We found in a project we carried out, which you can download stuff from our website, called Beyond the Usual Suspects. And there's loads of other free resources to get. So what I'm trying to say is that none of us, including me, have monolithic or uniform identities. Identities we know are very complex. My focus today is at a practical, philosophical, theoretical level on relationships between psychiatry, disability and different disciplines. And I'm going to be drawing on and raising issues about different kinds of knowledge. You'll see I still need to use notes, for which I apologise in a way. But I hope we've got lots of time for discussion, and we're very more spontaneous. But I believe that deploying, respecting different forms of knowledge adds to our insights and understandings. It encourages understanding rather than inhibits it. And let me say a crude example of why I think that's true, to have a better grasp, better closeness to other forms of understanding and experience. I think particularly because of the very visible in the last few years, appalling cases. I mean, I think that these things are a continuing issue, but sometimes they are particularly highlighted, and there are extreme versions of abuse, neglect, cruelty and inhumanity in health and social care services in the NHS and in those ancillaries operating on behalf of the NHS. Two examples that have been highly broadcast, of course, are Midstaff's Hospital and Winterbourne Grove. But of course there are other expressions of cruelty which we can associate with, for example, what's been going on that's now come to visibility, associated but not restricted to Rotherham and Rochdale, for example, in terms of large-scale systematic abuse of children and young people. And it seems to me that what I think about is how do these divisions between us as people, divisions which are embodied in cruelty and inequality of treatment, particularly between people as recipients of service and policy, people who manage, who control, and sometimes practice in such policies. And I can come to no good understanding of why this happens, except that we must have ways, we know that we have ways of being able to separate ourselves from the experience and feelings of other people. And anything we do which challenges that, whether it's an intellectual act, a practical act or whatever, must be something helpful, rather than mirroring the exclusions and the misunderstandings about other experience. So I'm raising issues about other different kinds of knowledge, of course, today. I want to pay attention particularly to the knowledges of people on the receiving end of policy, practice and research, people who tend to get categorised in one way or another as service users, or one of the groups constructed in response to the development of human services, policies and ologies, including disabled people, people with learning difficulties, older people, and particularly today, mental health service users, survivors. And what distinguishes, we know, that knowledge is its claim to be based on lived or direct experience rather than the expertise that comes from some kind of academic or professional learning or socialisation. Clearly there are many issues about such knowledge and distinguishing it from other knowledges. There are problematics here that need to be explored, questioned and given more thought to, and clearly I won't adequately be able to do that today, but hopefully some of that can come out in discussion. What we do know is that in fields like disability, mental health and so on, and in research, there's both a growing interest in and pressure for the inclusion of such experiential knowledges. And that's my starting point here. I don't want to minimise the problems that it may give rise to, continuing questioning of it, maybe in many ways justified questioning, and hopefully we can look at these. I just want to set the ball rolling in the context of my focus, which, as you know, is from psychiatry to disability studies and man studies, exploring uncharted relationships, where there's a concern to challenge disciplinary boundaries, as I've already been hearing in the session before, and not to be limited in our own professional or disciplinary viewpoints. And that's the first thing that I need to say about the knowledge that is coming from people as service users, to forgive that shorthand, that we can unpack it, and their groups and organisations and movements. People identifying and engaging as service users don't necessarily, of course, start from a discipline. People may do, may be pre-existing, they may be affiliated to some kind of discipline, whatever it is, but crucially, although of course all of us are open to influence, We will start from our experience, if we're not coming at it from a disciplined point of view, and how we understand it, how we've come to understand that experience, how we've come to interpret it, what's encouraged us to interpret it in one way or another. And that's why I think professionals have often said rightly that people as service users don't seek help or support in terms of particular policies or services. Why would they, us, do that? It isn't how we are likely to think, at least to start with, until we realise we have to negotiate systems. But for most of us, our starting point simply is, or complicatedly, is our lives. And we want to engage on that basis, not according to the particular histories and cultures of particular services, services which are often separate from each other, us, and these skills, serious skills, often class-based skills to negotiate, or disciplines which are different, sometimes competing and conflicting in their analyses and understandings. And that actually is why the organisation I'm part of, and we've been going now, I think, about 19 years, 18 or 19 years, when we set ourselves up, we determinedly called ourselves Shaping Our Lives, rather than including words like policy, services, profession or something in our approach, because our concern was with our lives, people like us's lives, to secure rights, needs and interests. So that's my introduction, where I hope I've been able to stress the limits of what I can hope able to do. Apologise in advance for that. I want to start now with my intended trip to elaborate on the title of this presentation. I hope, is this making sense all right so far to people? Thank you. And I want to start with the findings. This all sounds very bold, I think, next to some of the very nuanced kind of discussions which I was really enjoying hearing in the last session that I was in. This is to start with the findings from a national user-controlled, survivor-controlled research project supported by the Joseph Rowntree Foundation, which a group of us as survivor researchers have been carrying out, and it's going to be published this autumn. And it's a second stage project building on an earlier one which was reported in 2010, and the aim here was to gain the views of a wider range of mental health service users, survivors, and to find out more about how more social understandings of mental health might be taken forward. So let me take you through briefly the key findings from that. This is what people said, and we spoke to a very diverse range, about 80 plus people in this across the country. Most mental health service users, survivors who took part, feel that the public and professional interpretation of mental health issues is predominantly, overwhelmingly through a medical model as a medical issue, seeing a problem primarily in the individual. While many service users have themselves also internalised such a medical model, they associate it with an overemphasis on drug treatments, and most see it, quite unqualified, as stigmatising and damaging. That was one thing that there was some real unanimity about in this project, as in its predecessor. There was a strong lack of agreement, though, about the social model of disability. Some service users say they find it helpful as a basis for understanding their experience and situations. Others reject it and don't think it can be helpfully applied to mental health issues or wish to identify as disabled people. There are particular objections from some service users to the idea of having been associated with an impairment, although some also raise subtle complex issues in relation to that about who they are. At the same time, many service users feel it's possible and helpful to identify with and link with the broader disabled people's movement while retaining their own distinct identity as mental health service users. It seems clear to us from this project's finding that any attempt to impose the social model of disability crudely on mental health issues and mental health service users is unlikely to gain widespread agreement or support from those service users at present. Second, because the idea of recovery has become a guiding principle for UK mental health policy and provision since the first stage project, we asked participating service users about it. Participants had very mixed views about whether recovery is helpful to mental health service users, and it was put by one particular person very elegantly, and it sums up what people have to say. Most feel that the idea could be helpful, but the policy as implemented isn't. It perpetuates, they feel, a medicalised individual model of mental health. It's not based on listening to service users, there's a strong feeling that the idea which was supposed to be user-led has been hijacked by a narrowly framed government policy which puts increasing responsibility on the individual service user to deal with their difficulties, whose central aims are seen as saving money, cutting services, and most important, getting people off benefits into paid work, regardless of how realistic, appropriate, or helpful that might be for them. Now, people, while they were divided about the social model of disability, and we tried to offer a helpful, meaningful, non-consensual definition to support people who didn't feel familiar, most service users who took part in the project feel that social approaches to mental health, which take account of the whole person and wider societal issues affecting them, are the most helpful. Some feel that such social approaches need to be incorporated more widely in medical practice. Service users seem to value a holistic or combined approach which takes account of both the individual and their social circumstances. Our findings highlight the complexity of service users' views, their reluctance to impose monolithic interpretations on their feelings, understandings and experience, and a desire to take account of both personal and social issues. While some service users say they value some medical interventions, they draw a distinction between that and a narrow medical model and over-reliance on medication. While seeing benefits to be gained from social approaches to mental health, particularly for members of black and minority ethnic communities, they also see practical obstacles in their way. Most service users involved in the project strongly support the idea of developing discussion about such social approaches, particularly amongst service user survivors. Some feel that progress is already beginning to be made and that there's more preparedness now to think in such ways among some mental health professionals. And in the report we also set out a set of proposals and recommendations which came from participants, what they said, to give legs to such discussion and action to advance more social understandings of mental health issues. Right, pause for a moment. While the ever-expanding psychiatric project, as I see it, is one which many service users seem worried and fearful about, it's significant to note how many different disciplines and professional understandings which today reminded me about continue to underpin and connect with it. These, of course, include psychiatry and to some extent extend to psychology, medical sociology, social work, history, economics, political theory, and so on. And that's why I think it's no accident that those seeking to break out of psychiatry's medicalising dominance have largely not been confined, particularly to a particular discipline, but have been guided and shaped also by their lived experience, their sense of shared interests and understandings, linked with opportunities to achieve those, to reflect by coming together, reflect with people with similar or shared experiences. But things, of course, are really complex. So one of the additional findings for us from the project was that while there are widespread concerns about the medical model and associated terminology among mental health service users surveyed, service users are divided about the use instead of terms like mad and madness. Some thought they should be reclaimed, but others that they had too many negative associations ever to be helpful. Language really emerged for us from the project as a problematic issue, and as is, I think, more often, generally, but usually unstated that it is. We concluded that problems of language continue to constrain both understanding and progress in the, quotes, mental health field, and as I realised when I reread that, there you go, I'm constrained by it myself. We still have a very limited and unhelpful vocabulary for scare marks, someone said, for mental health. This emerged constantly in the project, so participants who were critical of the medicalisation of distress nonetheless frequently themselves used medicalised language, for example, talking about mental illness, mental health problems. On the other hand, the concept of recovery seems in practice to be an extent, which I think some survivors still hope can break out, to be an extension of the medical model, which of course some people as survivors do think offers hope a way forward. Language became a real issue for us in writing the project report, which we didn't resolve. We found ourselves having to use medically based terminology despite our own reservations about it. That's because there simply is no agreed language in this field, and there's nothing that we share about language, as I hope I've made clear by the uncertainty for many people about words like madness. And what one person favours may offend another. If we might feel more comfortable talking about madness and distress, as our project demonstrated to us from what people were telling us, it's a term that's become too degraded and too pejorative for some survivors to consider using it. On the other hand, we know now that some service users and allies internationally are determinedly using the word mad, especially under the banner of mad studies, which I believe sets out a new marker for those seeking to challenge medical models which service users, we also know, generally dislike and find unhelpful. And we need to remind ourselves, and I don't say this in a cursory or a careless way, we need to remind ourselves, or a disrespectful way, that terms like black and gay and indeed queer were initially rejected and sometimes ridiculed, but they have found their way, their place into liberatory politics, theory and thinking. So I do want now to turn to mad studies. In a way, the term I think is a misnomer. I believe that mad studies, which I think can be seen as an international movement coming of age, is based very much on the kinds of ideas we associate with Paulo Freire, ideas of conscientization, bringing together thought and action as practice. So it's not about, it calls itself studies, it's a form of modesty, I think. It's not about some separate or isolated idea of academic or intellectual activity. It is something much more than that. And mad studies has been defined, I think, in ways which make us sensitive to this. And you can read this on the Mad Studies website by Lucy Costa, who's a Canadian activist survivor. And I'll read out what she says. Mad studies is an area of education, scholarship and analysis about the experiences, history, culture, political organising, narratives, writings, and most important, the people in capitals who identify as mad. Psychiatric survivors, consumers, service users, mentally ill, patients, neurodiverse, inmates, disabled, to name a few of the identity labels our community may choose to use. Mad Studies has grown out of a long history of consumer survivor movements organised both locally and internationally. The methods and approaches for research are drawn from other educational fields, such as women's studies, queer studies, critical race studies, legal studies, ethnography, autoethnography, again, just to name a few, she says. But Mad Studies right here, right now, is breaking new ground. Together we can cultivate our own theories, models, concepts, principles, hypotheses, and values about how we understand ourselves or our experiences in relation to mental health systems, research, and politics. No one person or school or group owns Mad Studies or defines its borders. As explained in the book Mad Matters, Mad Studies is a project of inquiry, knowledge production, and political action. And as I said, I think it's a growing international movement. A key development in its history was the publication, which she refers to in 2013, of Mad Matters from Canada, which presents itself as, again modestly, as a national study, but I think it's much more than that. Canada, where Mad Studies has its key origins. So if I would suggest to anybody, maybe for some of us we need some guidance and help. I know that in my worst times I always found it very difficult to find sources of conventional information I could actually access. But if we want to suggest one resource to people in a position to make use of it as survivors, as families, that could make a real difference, then I think it would be a book like that. It's a substantial book in every sense, which I think, because of its substantial nature, can make it possible for us to have a building means to escape the tyranny of psychiatry, and what I see as the current cruel alliance between psychiatry and neoliberalism. They do really like each other's tunes, and at last find a really helpful way out of distress, madness, mental health problems, call it what you will. But at present, the medical model that underpins this, the treatment system and services, the dominant approach to research and analysis, are all seriously deficient, and I think we do need to try and find bold ways of breaking free. For me, the book is also living proof that people with direct experience, supportive professionals, academics, educators and researchers can equally together take forward mad studies and mad action. And here we can see the value, the strength and the possibilities of such alliances. It made me feel, coming across that book for the first time, that it was a struggle that because we did not as survivors have to be on our own here, we might truly, in the longer term, be able to win. So for me, there is a power to the new alternatives offered by mad studies, which I think I would sum up as being that it has grown with equal survivor involvement, it is international, it's flourishing, it's growing, it's unequivocally non-medical, and it makes possible, and it seems to reflect powerful alliances, crucially starting with survivors, survivor knowledges and research. And this was something that I was reminded of at the Peter Sedgwick event that took place a couple of weeks ago in this same building, which really strongly reminded me and offered some warnings from history. I'm personally wary of any theory, philosophy, organisational movement that is not led by service users, does not work hard to involve them as soon as possible, if not initially on equal terms, and does not value their experiential knowledge and user control research equally. So I believe mad studies can be helpful so long as it's led by us and our experiential knowledge as survivors, with committed allies treated with equality and demedicalised. Because I think we need as someone said to me, we need a convincing model to replace the conventional medical model, which has an amazing power over all of us. It's had power and in some ways still has a power over me. We know from research with survivors how damaging they feel that model and its drug-dominated corollary is and can be. It may not be helpful, but for many of us trained to be deferential, it's worked, it has seemed to make sense, it carries conviction, but it's a wrong thing, I say, for us to experience difficulties and for us to be written off as abnormal, pathological and deviant. The battles, I think, now are very much over language and ownership, over social and collective, rather than individual and individualised, and of course over neoliberalism and the well-being of the rest of us. And it's good to report that lots is happening. Last September there was the first mad studies stream at the biannual International Disability Studies Conference at Lancaster University. There's now a flow of books focusing on mad studies. The latest of these is the UK Madness, Distress and the Politics of Disablement, which was launched just a couple of weeks back. And then the following day there was an international seminar, again at Lancaster University, focusing on mad studies and neurodiversity, exploring connections. And this, for me, highlighted, amongst many things, loads and complex issues in relation not only to coming at things from different experiences and understandings, but where what is accessible and inclusive for one person may not be for another. And already one participant has written a lengthy blog highlighting some of the issues and difficulties for enabling access and comfortable, safe participation for people at events like that who identify as neurodiverse. I was involved in organising this. We tried to address these in how we organised the event. For example, providing graduated lighting, waving hands rather than clapping, providing a comfortable, quiet room, and so on and so on. It was also very much an occasion to learn about differences as well as overlaps, mistaken assumptions about consensus and agreement, first steps to have equal conversations, to begin to have some equal conversations and engagements with each other. These, for me, are, I'm sure for all of us, are terrible times for people who are included as disabled, as mental health service users, as neurodiverse. There is a ruthless political and ideological determination, I believe, to reduce state support and increase state control, to frame people in the crudest binary terms of independent, dependent, strivers, scroungers, part of us or other, as deviant, pathological, as citizens or asylum seekers, rather than human beings with equal rights, responsibilities and entitlements, as well as different needs and complex intersecting identities that people have a right to define for themselves. Which might of course make it seem like exactly the wrong time to be opening up the kinds of discussion we're having today generally, but also specifically the kind of discussion which I've been trying to take forward, exploring uncharted relationships between psychiatry, disability and madness, distress and difference, to challenge the sometimes hard-won certainties of disciplines. I would say, in fact, it's exactly the right time, a critical time, and that we should be developing such conversations. We should have pride in who we are, that we can begin to grow those understandings that we can have of each other, with each other, and rather than being pushed into some narrow defensive position, reacting to right-wing attacks, defending what in service terms has often been the indefensible. This is a discussion, I want to say, which I think needs to take place without frontiers, without disciplinary limits, without epistemic injustice or violence, where we can, all of us affected by these issues, and that truly means all of us in one way or another, can attempt to enable and be part of equal, inclusive discussion and activism. Thank you.